Hello, and welcome to the CCO Medical Specialties Podcast. I'm your host, Jill Frost. Today's episode features a discussion with two dermatology experts, Dr. Andrew F. Alexis, Professor of Clinical Dermatology at Weill Cornell Medical College, and Dr. Daniel C. Butler, Assistant Dean of Student Affairs at the University of Arizona College of Medicine, Tucson. Listen in as they discuss the immunopathogenesis and role of IL-13 in atopic dermatitis, using a detailed patient case to highlight key take-home points. This episode is part of a larger educational program titled IL-13 Inhibition in Moderate to Severe Atopic Dermatitis, a clinical skills curriculum to support evidence-based treatment decisions. For more information on Drs. Alexis and Butler, along with a link to the larger education program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about this important topic.
Well, I'm going to begin with a broad description of the role of IL-13 and how it kind of links to the clinical manifestations of atopic dermatitis that we see. And then I'll be turning it over to my colleagues for the remaining sections. We're going to have a lot of discussion in between too. So when we think about the pathogenesis of atopic dermatitis, we've learned so much over the past 10, 15 years and really understand the role of the barrier dysfunction and Th2 immune access and the various players that drive the clinical features that we see at the level of the barrier and further downstream. And it turns out that IL-13 is being a key Th2 cytokine, plays a central role in the pathogenesis of AD. In fact, it contributes to epidermal barrier dysfunction by downregulating important barrier proteins like filaggrin and laurin. It is a key driver of the Th2 response. It actually contributes to pruritus, itch, by stimulating sensory neurons, and there are actual receptors on sensory neurons for IL-13 receptors, so key driver of itch as well. It also can reduce the expression of antimicrobial proteins, which in turn leads to microbial dysbiosis with increased colonization with Staph aureus. And so these are just some of the key ways that IL-13 is really central to the pathogenesis and clinical manifestations that we see in atopic dermatitis. So what are the consequences of these various factors? Well, we know that with the compromise in epidermal barrier function, this leads to increased permeability, allergens, irritants, pathogens. And so these are the serious consequences of the compromised barrier, which then in turn would induce downstream immune responses that would manifest clinically as erythema and scaling and lichenification and oozing and crusting, and et cetera. Of course, on top of this, there's the effect of environmental triggers, which can exacerbate various aspects of atopic dermatitis, from climactic factors, exposures to irritants, stress, exposures to allergens, et cetera. I briefly mentioned about the importance of microbial dysbiosis with increased Staph aureus. There's also risk of other infections beyond Staph aureus colonization and secondary infection, viral infections, including molluscum, particularly in children. We can see widespread molluscum contagiosum, or eczema herpeticum when we see herpes simplex virus infections in the context of poorly controlled eczema and the compromised barrier. So just some of the dysfunctions that are very clinically relevant to our patients who suffer from AD. So with that, this set the stage for targeted therapies that can specifically target IL-13 and other key cytokines in the immunopathogenesis of this disease. Today, we're really focusing on IL-13 and two of the available agents that specifically target IL-13 are tralokinumab and lebrikizumab, and we'll be hearing more about those from my colleagues. We also have dupilumab, which inhibits IL-4 and IL-13 signaling by binding to the IL-4 receptor alpha subunit and thereby blocking both IL-4 and IL-13 signaling. And as I mentioned, when it comes to the sensory neuron, they're actually receptors for IL-13, and this contributes to the pruritus that we see. All right, so with that background, let's take it to a typical case. And the first case is a patient named Jane, who's a 34-year-old woman who's complaining of worsening symptoms of her atopic dermatitis over the past year. She reports persistent itching, redness, scaling, despite adherence to her topical corticosteroids and emollients, which she's been using for a while. She has severe pruritus that disrupts her sleep, and she's growing increasingly frustrated that her current therapy, worked initially in the short term, but she reports it only providing temporary relief at this time. Past medical history, other than having moderate atopic dermatitis since childhood and now progressing to more severe disease, there are no other significant medical history there. Physical exam, she's got widespread erythematous plaques, excoriations, lichenification, as well as post-inflammatory hyperpigmentation. She has richly pigmented skin type probably a phototype 6, with the erythema is not just red. There's a sort of a deep red, brownish hue, and in some areas even a violaceous to gray hue within this lesion. We see excoriations, we see lichenification, we see scale, and it's involving the antecubital fossa, it's involving the forearm and the wrist and other areas. And some of the areas are particularly lichenified and raised. So clearly not well controlled at all. And then you couple that with the pigmentary changes, you can see why she's quite distressed. Let's have a little discussion about how does IL-13 contribute to a patient like Jane? How does it contribute to the barrier dysfunction? And what about her description of her symptoms worsening despite having an initial response to therapy or topical corticosteroids and emollients that she was using? What's the potential mechanism here? I'd like to invite my colleagues, Doctors Butler and Quatra, to chime in as well. So let me start with Dr. Butler with that first question. What do you think here is the contribution of IL-13 to barrier dysfunction and atopic dermatitis in general?
Well, thanks, Dr. Alexis, and tour de force so far on IL-13. I think we're all sort of putting together some of the pathophysiology of AD that we know sort of simplistically with, the barrier disruption, there's immune overactivation, there's a propensity for overcolonization of certain microbial species. But when it comes to the barrier dysfunction, we definitely know that, there is an impact on the keratinocytes from IL-13, and that disruption is ultimately a huge part of the breakdown in this patient's presentation. So I like to simplistically think of it as just there's a direct barrier disruption there. IL-13, how it contributes to that is that it really impacts the specific keratinocyte. And I think that's the thing that I want to get across to all the learners here today.
Yeah, thank you for that. That's a really good point to emphasize. So how about when you think about this patient's description of, well, I was doing well initially with the topical corticosteroids, but they don't seem to work anymore, or certainly not as well as they used to. And it feels like I'm only treating the symptoms partially, but I'm not getting the type of control that I'm looking for. What do you think is going on here?
Yeah, I think, first of all, I just commiserate with everyone in the audience here, and certainly the patient, which is like, we've heard this story before, right? Everything's getting worse. Nothing, I was better for a period of time, but overall, I just keep having these blips of really bad symptoms. And I think that thinking of atopic dermatitis, not just as a sort of one-trick pony, meaning like there's just one error that needs to be fixed. And that's why I like the discussion here of talking about both the barrier disruption and some of the immune dysregulation. Because I think when you're just using topicals, you're probably only solving one of those parts of the equation. You're probably only hydrating the skin or only getting rid of a modicum of the inflammation that's going on. But I think we really need to think about AD almost as a Venn diagram, that there's disruption of the barrier that ultimately leads to some sort of microbial species growth, which ultimately leads to some immune overactivation. And I shouldn't be leading and saying that one goes to the other, because we're not really sure what comes first, the chicken or the egg. So in this situation, I do think that it's a product of just having one sort of more mild treatment, like a topical steroid. You're only going to cover one or partially a couple of the Venn diagram parts. You really need more targeted control to be able to get more significant disease control overall.
Yeah, well said. And so when you're with a patient like Jane, is this a scenario where you might consider moving away from just topical therapy alone to systemic therapy?
100%. I think with the availability of all these new medications out there, this discussion has, perhaps gotten a little bit more complex, but I personally enjoy it a lot more because I know that I have more in my hand. And I think this is, a product of shared decision making, not forcing somebody to go to a biologic or a more advanced medication. But as you're explaining the disease, it used to really be, topical immune suppression and then more significant oral immune suppression. And now with these newer agents, we're able to really attack that Venn diagram of contributors of disease with these biologics. And so it's kind of it's a pleasure to be able to prescribe some of these medications that we know are going to hit on several of those contributing etiologies: barrier, inflammation, staph overgrowth, and to do it in a safe way. In this patient's case, I think that's a no-brainer.
Thank you, Drs. Alexis and Butler. And many thanks to you, our listeners, for joining us. As a reminder, to view the full program, IL-13 inhibition and moderate to severe atopic dermatitis, a clinical skills curriculum to support evidence-based treatment decisions, please click the link in the show notes. And be sure to check back regularly for more episodes on important medical specialties topics.